Hello and welcome to your Chapter 20 video lecture on the alterations of hormonal regulation. Hopefully before watching this video you had a chance to review Chapter 19, which really goes through a review of the AMP when it comes to the endocrine system. So in this chapter we're going to talk about how do we have dysfunction take place within the endocrine system and what mechanisms does that happen within. So we can alter the hormone level due to having an inappropriate amount of the hormone that we're trying to deliver to the target cell. So essentially, endocrine system dysfunction is caused by either a hypersecretion or a hyposecretion of a hormone. And this could be due to a disorder within the endocrine gland itself, causing them to synthesize too little or too much of it, like we said, a hypersecretion or a hyposecretion. It could be a failure of the feedback systems that we have in place to really control how that hormone is released and regulated. It could be due to dysfunctional or ectopically produced hormones, meaning that they're produced from non-endocrine sources. So for someone with endometriosis, they have the endometrial tissue growing elsewhere and that can secrete certain hormones. Or it could be due to defects in delivery of the hormone in the bloodstream. So typically what we see, here's an example, we have a hormone, it attaches to the receptor, and that kind of activates a certain cascade. It can either do that on the plasma membrane if it's a non-steroid hormone like a peptide hormone, or if it's a steroid hormone, of course, it's going to pass through the plasma membrane and attach to a receptor in the cytoplasm or within the nucleus. But what we can also have happen is an inappropriate response by that target cell, and that could be due to abnormalities in the receptors. You can kind of see that pictured over here where we have too many or too few receptors on our target cell, or maybe we have enough receptors but they're abnormal or they're insensitive to the hormone. We can also sometimes have autoantibodies that can attack these receptors, or they can attach to it and block it so that the actual hormone can't attach there. We can also have intracellular disorders. Like we said, we have a full cascade that takes place here. So it could be within one of those secondary messengers, such as cyclic AMP, that gets affected and is not routing the proper cascade in order to get the cellular effect that we need from that hormone. I also urge you to check out table 20.1 in your book. It kind of goes a little bit more into detail regarding these different alterations. We can also have an alteration between the hypothalamic-pituitary system. If you remember, our hypothalamus would create releasing hormones and inhibiting hormones that would then travel down to the pituitary gland and tell it to release or stop releasing certain hormones. And so we can have an interruption of that stalk, and this could be due to destructive lesions, rupture after a head injury, a surgical transection, or a tumor that is really affecting the communication between the hypothalamus and the pituitary gland. Now, I put this over here too, but this is more of a congenital type of disorder where we have an interruption of the formation of the pituitary stalk, so there's no communication between the hypothalamus and the pituitary gland. So now, as you can imagine, without having that input from the hypothalamus, we now are going to have a decreased release of the releasing hormones, our gonadotropin releasing hormone, thyrotropin releasing hormone, our corticotropic releasing hormone, our prolactin inhibiting factor, and then our growth hormone releasing hormone. All is decreasing, right? So all of that is not being sent over to the anterior pituitary gland. So as a result, we are going to have decreases in FSH, LH, TSH, our ACTH. But notice how we have an increase in prolactin, and that's because the control of prolactin is predominantly inhibitory by the hypothalamus, which is kind of what we were saying up here through dopamine. So we're going to talk more about that a little bit later on, but then also notice that we have a decrease in the growth hormone. Now let's start getting into some specifics and talk about diseases of the posterior pituitary gland. So we'll start off with the syndrome of inappropriate antidiuretic hormone secretion, also known as SIADH. And this happens because we have a hypersecretion of ADH, which is also known as vasopressin. And this could be caused by a production by tumors, such as cancers from the lung, stomach, pancreas, bladder, prostate, and the endometrium. It could also be due to lymphomas and sarcomas. Or it could be due to pulmonary disorders that would be like pneumonia or asthma, cystic fibrosis, or respiratory failure, or any CNS disorders such as encephalitis, meningitis, intracranial hemorrhage, tumors, like we just said, and trauma. And then we can also have it take place due to surgery, and these are largely iatrogenic and can cause ADH to be increased for as long as 5 to 7 days after surgery. And this could be due to the fluid and volume changes after surgery and the amount of intravenous fluids that was given to the patient, or maybe they were given narcotic analgesics. And then certain medications can also cause this to take place. Now, if we think of what ADH does, is it is going to attach to a receptor, and this is taking place in the nephron. And let's just refresh our memories. So here is our kidney here, and then along this region, the cortex and the medulla here, that's where we're going to find our nephrons. So when we look at the nephron, remember we've got our renal corpuscle with the glomerulus over here, and then the Bowman's capsule, our proximal convoluted tubule, the loop of Henle or the nephron loop, our distal convoluted tubule, and the collecting duct. So within the distal convoluted tubule and the collecting duct, this is where we are going to have those cuboidal cells lining the tubule, right? And so that's what we're seeing in this image over here. This is inside the tubule, whether you want to think of the DCT or the collecting tubule. And then this is where the capillary is, or the blood side of things. Of course, there's some interstitial tissue or fluid sitting between the actual capillary. But what vasopressin or ADH does is it attaches to the receptor, and then it creates these aquaporin 2 channels here, and that allows the water from the urine side, our filtrate in the nephron, to move into the cell. And then we've got other aquaporins here on the side of the cell that is going to allow that water to be reabsorbed into our blood. So what that does is it enhances our renal free water retention. We're reabsorbing more water. And what that leads to is an expansion of our extracellular fluid volume that can lead to dilutional hyponatremia and hypoosmolarity. So to revisit that, let's take a look at this over here. Of course, this is our isotonic solution when all of the solutes are kind of evenly distributed. But as we're adding more and more water to the solution here, that is decreasing the amount of solutes, right? So it is decreasing our osmolarity. And because we are reabsorbing all of that water, what happens to the urine is it starts to become more and more concentrated. So you're going to start seeing urine more of like this dark orange or even brown color. So due to this extra water reabsorption, that hyponatremia is going to cause clinical manifestations depending on how severe it is. So we may have increased thirst, impaired taste, anorexia, dyspnea on exertion, and fatigue when the serum sodium levels decrease rapidly. Now, the way to treat this is to correct the underlying problem or cause of it. We also want to restrict fluids and carefully monitor their sodium status and look for any neurological symptoms. We can also give them Vaptans, which is going to be a vasopressin receptor antagonist. Now, if their SIADH is severe and we need an emergency correction of that hyponatremia, then we need to do careful administration of hypertonic saline. And in this way, we can increase their sodium levels. Our next disease is the opposite of SIADH, and that is diabetes insipidus, or DI. This is going to be an insufficiency or a hyposecretion, you could say, of ADH that is going to cause one to lose too much water in their urine. So we have two different forms of this. We have our neurogenic, also known as central DI, and this is when we have the insufficient secretion of ADH, which could be due to a lesion of the hypothalamus, of the pituitary stalk, or the posterior pituitary gland. Just as a review, remember that that paraventricular nucleus is going to create ADH, and then it is going to move through the neuron, through the stalk, and into the posterior pituitary gland, where it will be stored until it's needed to be secreted. It's also known as vasopressin, as we talked about, but it's also known as arginine vasopressin, or AVP. And this type happens to be an abrupt onset and could be caused by brain tumors, traumatic brain injury, hypophysectomy when we are trying to maybe remove tumors from the hypophysis, the pituitary gland, aneurysms, and other disorders. It could also be hereditary. The other form is nephrogenic. So I want you to really think about this. Here we see neuro, meaning it has to do with parts of the brain, right? Whereas nephro, that refers to the kidney, right? So here we're going to see inadequate responses to ADH, which is, if you remember from the previous slide, let's go back one. ADH was going to attach to a receptor within the kidney tubules, the nephrons, right? So that's why we call it nephrogenic. And this is a gradual onset and could be either acquired or due to genetic causes. So if it's acquired, it's usually due to a disorder or drugs that damaged the renal tubules. Whereas if it's genetic, there's some type of mutation, and you can kind of see the different types of mutations here that are coding for the aquaporin 2. What we saw in the previous slide here, these aquaporin 2 channels. There are 4 aquaporin channels that exist. And there's also actually a third type. Your book doesn't really talk about it as a form, maybe because it's rare or temporary due to someone being pregnant, but it's known as gestational DI, and it's going to be due to an increase in an enzyme known as the vasopressin degrading enzyme, which is known as vasopressinase. And that essentially is breaking down or inactivating ADH so that it is deficient. And so within pregnant people, it's mild and it typically doesn't require any treatment. So as a result of this, we're going to get large volumes of dilute urine, which is going to cause an increase in plasma osmolality. Now, our body's normal plasma osmolality is between 275 to 295 milliosmoles per kilogram. Let's just go with a 300 to make it an even number. And so when we increase that, we can go up to, let's say, 500, 600, and we have so many more solutes in here. And you could think of our blood as almost being more concentrated, right? There's not a lot of water in this area. And so some manifestations that we can have is polyuria, again, having the large amounts of urine, nocturia, and continuous thirst, polydipsia, and that could lead to dehydration. And what they see is that these patients are still secreting large amounts of fluid despite them being dehydrated. So that is a clue that they have DI. And of course, because we're losing so much water, there may be a weight loss associated with that. If we can't conserve as much water as we're losing in the urine, then it may also lead to serum hypernatremia and hyperosmolality. So to treat this, for the neurogenic type, is going to be just fluid replacement, and this could be oral or IV. And some are going to require ADH replacement. And for the nephrogenic form, you just need to treat the reversible underlying disorder.